Hi, everyone. I'm really excited to be joining you today from a sunny day in Toronto. I don't know what it's like in Cleveland right now. I'm so sorry that I can't be there in person. I hope it's been an amazing symposium. I'm really honored to be able to present to you today. And I'll be talking about mental health. It's funny for me to be talking about this topic because I'm both training to become a healthcare, like a mental health provider. You know, I'm in my fourth year of residency in psychiatry now. I'm also a learner. I skirt these two worlds. So this is really exciting for me, and I'm really honored to be able to talk about this today. I'm going to share my screen now, and we'll get started. So, like I said, we're talking about mental health. We're talking about psychological disability in the health professions. Like I said, I'm in medicine. A lot of this talk is going to be centered around, or not centered, but is going to be informed a lot about the medical profession journey or pathway. And I think a lot of what we talk about today is going to be extremely relevant to all health professions. The same barriers exist, the same cultural factors that go into understanding how someone can actually succeed as a healthcare professional with a psychological disability. Ooh, there we go. So I have nothing to disclose for this presentation. Just an outline of what we'll be talking about today. So we're going to start with a case. I'm really sorry. I'm a clinician now. Like, we always start with a case, but I think it makes it a lot more human to think about. Okay, here's someone who steps into our office, and how do we help them? How do we understand the barriers that they're experiencing? Because I think, as we're going to talk about today, intersectionality is a huge part of understanding any disability, but I think especially psychological disability, because a lot of that is invisible. So what are some of the other factors that play into someone's experience going through health professions education? I'm going to talk about some research on psychological disability. We're going to go through the pathway of health professions education. I'm warning you, it's a long path, and we're going to talk about that path. And finally, we're going to end with why we actually need to include health professionals with psychological disabilities. That's why we're here. That's why the symposium is happening. And I think it's just really, really great to be able to end with, this is why this is all relevant. This is why we're doing the work. So without further ado, I'll get started. So just to start, again, I signaled we're going to start with a little case. So Charlotte is our case today. She's currently a pre-medical student. She's interested in psychology. That's her major. She lives at home with her mother and her 3 younger siblings. Since she's been a teenager, she played a caregiver role in her family because her mother was experiencing health difficulties. So she's caring for her mom. She's also caring for her 3 younger sisters. We'll say they're sisters. She's very conscientious. She's what we would say she's like that caregiver style personality. She's hardworking. She tends to be hard on herself. In psychiatry, we would say she has a harsh superego. That inner voice is always telling her, you should be doing this, you should be doing that. In college, she becomes overwhelmed by school demands, family demands, and she develops severe anxiety with panic attacks. And they're starting to interfere with her functioning at school. When we think about anxiety, we think about symptoms of not just being like completely frozen and unable to get things done, but also like it impacts concentration. That's one of our diagnostic criteria for anxiety. So again, we can sort of immediately imagine in our head, what are some of the functional limitations that might be happening here in college? But Charlotte, she's really lucky. Her college's student health services provide her with a psychiatric assessment. She gets a diagnosis of generalized anxiety disorder and panic attacks. And her school is really great. It's well-resourced. She gets a combination of psychotherapy. She gets treatment with medications. She also gets accommodation. So she gets really good wraparound support. And she's able to catch up on her coursework, and she's able to excel. And it's funny, like, oh, wow, it never happens like this. It's never that simple. And at the same time, we know that when psychological disabilities are treated and accommodated, people can function. And I mean, this is your work. This is your expertise. It's sometimes it's really just people just need access. So this is her pre-medical career. She's really interested in medicine. She loves psychology. She says, maybe I want to be a psychiatrist. she's encouraged by her mentors and her psychiatrist to apply to medical school. And so she's like, okay, well, what's involved? Okay, the first step is, she has to write the MCAT. Then she has to go through admissions. And then, things go well, she gets accepted. But then there's way more to that. She talks to someone, she maybe buys them coffee and is like, okay, I'm interested in medical school, what's involved? They're like, oh, okay, well, after you're accepted though, that's when it really gets started. You then have preclinical years, then you have the step exam, then you have clerkship, then you have another step exam. And I'm Canadian, I didn't have to write the step exams. My sincere condolences to everyone who's ever had to write these exams. They sound just really, really hard and not necessarily long. Anyways, I'm sorry if there are NBME people in the audience. In Canada, our exams are slightly different, and actually the second exam that happens during residency has actually been canceled indefinitely because of changes in the way that the medical education structure has changed. Okay, then after the second step exam, we have the residency match. We have residency, we have exams, like licensing exams or board exams, and then full licensure. So I put this on the board or on the slide because it's a really long path. It's a really long journey. And it's overwhelming. Like I look at this and I'm like, I'm almost at the end. Like I'm at the end of my residency. I have a year to do my exam. And it's like, wow, I can't believe I did all that. So we imagine for Charlotte being at the very beginning before she's even applied, before she's done her MCAT, this is really, really intimidating. So let's talk about psychological disability. Lisa Meeks has really done, obviously, like she's done so much for this field to understand, what is even happening? Like what are the numbers we're dealing with? What are people experiencing in medical education? And psychological disability represents the largest category of disability in those who self-disclose a disability to their medical school. So 32.3% of students in 2019 who disclosed a disability to their school had a psychological disability. What is a psychological disability? So a mental or emotional condition that affects social, educational, or vocational functioning. Examples: depression, anxiety, trauma, bipolar disorder, psychosis, substance use disorders. And in mental health, we know that these diagnoses are never static. Diagnosis is an art in itself. From 1 month to the next, the diagnosis may actually change. So what may now be diagnosed as generalized anxiety disorder might actually turn out to be, in a couple of years, it might become clear that actually this is trauma. This is like a complex trauma from childhood. And so we have to be really flexible in how we think about diagnoses and realize that there's no one size fits all. So thinking about, that what we saw in Lisa Meeks's data was self-disclosed to the school. When we look at people who disclose symptoms or who report symptoms, not to their school, but sort of to surveys, we have really high numbers as well. So the prevalence of medical students with depression and depressive symptoms is alarmingly high, 27.2%, and that's just depressive symptoms. The prevalence of medical students with suicidal ideation is also extremely high, of 11.1%. When they get to residency, it's about the same. It's 28.8% who experience depression or depressive symptoms. And yet we know that very few of them actually will seek help. So I want to come back to the pathway. I want to come back to that really intimidating chart that Charlotte is about to embark on. So we have this journey. We have these many, many years of really intense work. And I want to take us through those and think about what are some of the barriers and what are some of the potential enablers that Charlotte may be able to kind of access during her educational path. So I want to first, though, point out that Charlotte is not a blank slate. She's not, coming to this path as someone who has no life experience and who hasn't learned from life already. She's already learned from her disability in the sense of she knows how to take care of herself. She's been through treatment. She's been through therapy. That provides her with a skill set to manage herself in a really important way. And yet her experience in health professions education is going to be affected by all aspects of her identity, which often do not get recognized or honored by the medical education process. So her race, her gender, her sexuality, her socioeconomic position, her religion, and of course her disability are going to inform the way she navigates medical school and the advantages or disadvantages she experiences. So they're going to, like, her intersectional identity is going to influence her access to mentors, career development opportunities such as leadership or research positions. And this is all just before she's applied to medical school, by the way. It's going to affect her access to healthcare. If she can't afford a therapist, it's going to be much harder to manage her psychological disability. It's also going to affect her sense of belonging. The more someone is sort of underrepresented in medicine, the harder it is to integrate and feel like you belong, which is an incredibly difficult experience, given that already medical school is so hard, already health professions training is so absolutely alienating in so many ways because you're just overwhelmed with the demands. To feel like you don't belong is just an added step to this already very difficult process. It's also going to influence things like stigma and discrimination. It's going to influence barriers to accessing healthcare and barriers to participation in general. So we're now in the steps. She's initiated. She does her MCAT. She's now at the admission stage where she's, applying to medical schools. And here's her application. She's got a good MCAT score. She studied really hard, but her GPA is not competitive. She doesn't have research or leadership experiences, and she only has one volunteer experience. So someone who's in the admissions committee is going to say, there's lots of applications that are more competitive than this one. And yet we know that Charlotte is such a conscientious, hardworking candidate who brings so much of her personal experience to this. She knows what it is to experience healthcare. And so she has a really good window into what it would be to be a good doctor. And so if we look at the sort of hidden meanings of these aspects of her application, we know that the GPA is not competitive because her grades in second year were lower because of her untreated anxiety disorder and there were no accommodations. And we know that she got her grades up once she did get accommodated. We also know that she didn't get research or leadership experiences because she had caregiving duties and she was in psychotherapy. So, she doesn't have 1,000 hours a day to work with. She's got the same amount as us. I had to think about that. I was like, how many hours are in a day again? 28? No, it's 24. But we pretend it's 28. And she only has one volunteer experience. Again, because she's working part-time during the school year and full-time in summer to be able to pay for college. So again, these are ways in which there's unseen factors related to her intersectional identity that relate to whether or not she even is seen as a good candidate for medical school. This is a paper from Nicholson and Cleland that discusses the concept of social capital, which is really what I'm getting at here with the idea of how does one's social position, race, gender, class, disability, how does that influence your ability to access spaces? And here's a quote from their paper. We drew on theoretical models of social capital. So then that's a socio-cultural theory to understand how individuals access and create resources or struggle to, which enable them to be successful within medical admissions and education. So I really recommend this body of work for understanding some of the unseen barriers, especially in the admissions process that relate to intersectionality. Okay, so we're back on the path. She gets through the admissions process. She's accepted. She's like, oh my God, I'm accepted to med school. This is so exciting. And then she starts pre-clerkship. So the journey is only beginning. So barriers in pre-clerkship, we know that there are many. This is something that you have expertise in. There's attitudinal barriers, pedagogical barriers, financial barriers. From the attitudinal side, there's, the biggest thing that we think about with mental illness is stigma. Also, the lack of role models who actually disclose their own disabilities in medical education. Imagine if she had a preceptor who just mentioned, by the way, like I had depression in residency and I got treated. How different would that be for Charlotte? Also, Charlotte is warned by classmates or by, an upperclassman that disclosure is going to affect the residency match, and it's going to lead to a forced leave of absence. And so, of course, that's going to be a huge barrier to help seeking for her. There are also pedagogical barriers. So the medical school environment itself is not very flexible. We know that. There's a high volume of didactic material and pre-clerkship to memorize. No access, let's say in her school, there's no access to recorded lectures, and lectures and labs last all day with few breaks. Now, Charlotte is a person who is expert in her disability. She knows how she needs to work to be able to succeed. And yet the lack of flexibility in medical school without accommodations is not allowing her to use those tools that are very tried and true and have allowed her to succeed in the past. There's also, of course, financial barriers. If there's no psychotherapy that's provided through her school, what if she can't afford private therapy, which again was something that helped her succeed in the past? Let's say she's also working part-time on the weekends to pay for school. That limits study time, which is going to affect her ability to feel like she can succeed and belong in medical school. So that was pre-clerkship. I'm not going to talk about the STEP exam because I haven't done it. I don't have a window into that. There's really, really great research that's been happening about the STEP exams. I want to focus on clerkship because I think that's a really fruitful and a really important time in someone's professional identity development, is when they hit the ground in the clinical world. This is work that I have done with my supervisor, Dr. Martin Mianakis in Toronto. This was an interview study with Canadian medical students with disabilities, and their experience with what I was just talking about, like this idea of professional identity formation, and the hidden curriculum. And so when we talk about the hidden curriculum, what we mean is all of the unseen aspects of education in medicine. It's, you have your formal lectures, you have the stuff that's on the syllabus, and that's the formal curriculum. The hidden curriculum is everything else. It's the language, it's the policies, it's what's said about patients behind closed doors or said about diseases, that's not on the lecture slide. Because that is what we're seeing in the literature, is that is probably the biggest influence on how students understand what it is to be a doctor, what it is to be a patient, what it is to be a student. So what we found in this, in doing this critical discourse analysis of interviews with students with disabilities, is that there are these two main discourses of medical school. One is that they have this perception of what it is to be a good student. What are the expectations, essentially? What does medical school want us to be? And then there's this other discourse of the good patient. How are patients discussed? How are they modeled in medical school and healthcare environments? So the good student is one who regularly performs physically and emotionally demanding work. They're high functioning, they've got a million demands, and they all just beautifully juggle them. They sacrifice self-care or balance in order to study or socialize. They're very keen to go beyond the curriculum, and they engage in research and extracurriculars, and they don't call in sick or ask for help. Now, this one is an important one for me, where I wonder if COVID has shifted this or changed this. I do wonder, because on one hand, like, COVID has sort of normalized that you just don't come into work sick because you'll expose everyone. So I do wonder if that, I do wonder if that has changed. So here's a quote from one of the people that we interviewed. I talked to a student who thought that she was the only one who ever failed the test. Nobody talks about it. Nobody admits that they failed. There's no healthy environment where that happens. And this was a year 2 student with a psychological disability. Thinking about the good patient now, what was this discourse? What was the perception of what makes a good patient in medical education? There's someone who manages their own health by prioritizing health and self-care. Oh, we see a contradiction suddenly. They're low maintenance. They regulate negative feelings. They remain positive. Just a quote from one of the people we interviewed. It's challenging, especially in the first year. My being a patient was a full-time job, and being a medical student was a part-time job. It's extremely hard to have to do both. And, on top of that, like, let's say we know Charlotte is also a caregiver. So imagine she's got 80 full-time jobs to suddenly manage in her 24-hour workday. The other thing that we looked at in the study was this idea of professional identity formation and how is the discourse of medical school affecting that. So we saw two mechanisms. The first was this idea of identity conflict, moments where the patient-student roles, these dual roles, are experienced as jarring. And the other one was identity merger, where the dual student-patient role is actually an advantage. It's seen as something that can actually help them. So these identity conflict moments were ones where students found the curriculum content jarring, provoking a strong emotional reaction. People talked about, for example, crying in lecture or having to take a moment after seeing a patient, talked about by their supervisor, and having to sort of just go and cry in a corner because of how they saw the patient was treated. They talked about feelings of alienation and otherness from their classmates because they felt, that they weren't really seen or that they felt foreign to the curriculum. And they also talked about implicit attitudes towards illness in the hidden curriculum. For example, seeing a patient with a psychological disability in the emergency room asking for pain relief, and that immediately gets labeled as drug seeking, for example. A quote from a year 3 student: "I would say in general, it's hard not to feel like some classes are about you. And I had weeks where I sat through class and I felt very exposed." So we can imagine Charlotte, she's in clerkship or she's in pre-clerkship, and she's carrying this with her. She's carrying all of her experiences with her, which are not acknowledged as a thing that people can bring into medical school with them. We don't talk about psychological disability. We don't talk about disability in general, but because of the stigma attached to mental health and mental illness, it's especially invisible and especially something that she needs to protect and hide from people. And so imagine carrying that secret around with you in lectures about generalized anxiety disorder, or carrying that with you on the wards in your psychiatry rotation or any rotation where there's a patient who's really anxious, rightfully so, about their health. And then, a supervisor or preceptor might make an offhand comment of like, "Oh my God, this patient is so anxious." How do we think that Charlotte's going to feel about that? But there were also these moments of identity merger. Like people in our study talked about understanding the meaning of illness and disability for patients and families, being able to understand how hard it is to navigate the healthcare system, having improved communication with patients, and having a deepened understanding of advocacy and systems level change and how important that was. So a quote from a year 4 student: "Some of the feedback that I actually got from many of my preceptors in specialties like family medicine and psychiatry is that I'm very compassionate and that patients really seem to like me because I can communicate in a way that I understand them." So what people were able to see in their experiences was, yes, there were so many challenges, and their disability identity gave them so much richness with which they could connect with patients and become excellent doctors. So back to the barriers, though, we have these people who are so well primed to become these excellent physicians. And yet there are so many barriers to be able to access the supports that allow them to succeed. I had the real luck to be able to work with Lisa on this Viewpoint article about cultural barriers to help seeking. And sort of the summary of this is that, there's this stigma of psychological disability, and where there's, when we talk about psychological disability in medical school, it's symptoms are normalized. It's like, oh, but it's normal to be like extremely burnt out and depressed and anxious. Which means that, oh, well, that's not an appropriate thing to ask for help for. There's also these huge mixed messages in the curriculum where the curriculum might say, oh, yes, we really think your wellness is important. But in sort of like behind closed doors, students are still rewarded for staying post-call or for taking on more than they can, like biting off more than they can chew with research projects. And they're seen as, oh, wow, you've really soldiered through. The learning environment itself also just drives distress. The term that I would use in psychiatry is medical school is depressogenic. It is an environment that is really setting the stage and the conditions for someone to experience mental distress and potentially to the level of impairment, where the lack of sleep, the moral distress faced in treating people, and also experiencing learner mistreatment, which we know is extremely common. All of these are going to drive distress. And finally, a poor understanding of accommodations, both from students who don't understand necessarily that psychological disability is something that can warrant accommodation if there's a functional limitation. And also sometimes their schools might not understand how to engage students or how to get them into the door if they do have a psychological disability that warrants accommodation. So we're back to the map. Hopefully it's familiar by now. So Charlotte gets through clerkship. She gets through the residency match. She matches. We're really excited for her. She's in psychiatry now. Once she gets to psychiatry, when she gets to residency, there are still barriers. There are still parts of her intersectional identity, including her psychological disability, that are going to affect her experiences. I love this paper by Lisa and her colleagues. It's about mixed messages in residency training, which is what we were talking about with this hidden curriculum. A summary of this paper, a quote from this paper: residents are told that self-care is critical to avoiding burnout, yet that same messaging is absent for their faculty leadership. Working while sick, sacrificing personal relationships for work, and forgoing self-care are the norm, not the exception. So this is the idea that the curriculum says one thing, but the reality is another. And that is very prevalent in residency, where also it's a very unique position. It's different from medical school in the sense that you're also an employee. You're a learner, but you're also an employee who has responsibilities to cover. You're there overnight and you're the only person there overnight. So some of the barriers to help seeking in residency that's highlighted in this work is the system flexibility is even less because now you're carrying responsibility as a resident. So when you've got an 80-hour work week, it's really hard to attend to your relationships and your health and your family. Also, if you do take a leave of absence or you have to take some time off, you have to navigate this really intense coverage system of how do I get backup to come in? And how do I not burden my colleagues by taking a leave of absence? That's a really common concern among residents. And then disclosure is often directly to clinical supervisors if you do need to take time off. And these are the same people who are actually responsible for writing recommendations and for hiring in the department. So that's also going to carry a ton of risk and very naturally would be a barrier to disclosure. And then finally, licensure is the end of the whole pathway. And there's a lot of lack of transparency in that process. And what are going to be the consequences of disclosing a mental health or a psychological disability on licensure and hiring? I love this study. This is also from Lisa Meeks and a team that looked at the intern study. So they looked at depressive symptoms and perceived impairment among physicians in intern year. This is a large survey of US residents or US interns. And I'm not a quantitative person. This graph is very confusing to me, but I can say this. It takes me like 10 minutes to fully parse this. I'm a qualitative person at heart. But what we see, so just to kind of navigate us, so the blue curves are during internship, and the gray or the taupe, I'll say taupe curves are before internship. So basically, we're looking at depression scores or PHQ-9 scores for depression severity at the before internship and then during. So what we see is that during internship, depression scores go up. That's pretty common. We're not surprised. It's a depressogenic environment. But what's strange and what's interesting about this data that's really, I think is such a key finding is that the level of, or the severity of depressive symptoms that are considered to be impairing or very or extremely difficult, that's this top area, the severity of that is increased. So essentially, to be considered impairing, the depressive symptoms have to be much more intense. So what is it saying? It sort of speaks to the fact that some level of mental distress or psychological distress is normal or is perceived to be normal by interns. So as they go through intern year, they kind of start to accept that they're always going to be depressed or they're going to experience these depressive symptoms, which is really alarming. And I mean, I think this is such important data to have because it just shows us this is what's happening in residency. We're normalizing distress and not saying that it's something that warrants accommodation. This is another from the same kind of intern study, looking at program access and depressive symptoms and how that actually relates to medical errors among residents with disabilities. So again, we've got like over 1,000 residents responding to questions about having a disability or not. And that then gets divided in the survey between people whose access needs were met and those that were unmet. And so when their access needs were met, they had the same increase in depressive symptoms as non-disabled residents. But if their needs were unmet, they actually showed a higher increase in depressive symptoms in intern year, which is really critical. We can see that they're experiencing a higher increase in psychological distress when their needs are unmet. This is pretty clear, a clear need to meet people's access needs and to actually recognize what those access needs are. Similarly, we look at medical errors, and these are self-reported medical errors. So if access needs are met, there's the same likelihood of medical errors as non-disabled residents. But if access needs are unmet, these residents report a higher likelihood of medical errors. And I apologize, I know in the US, we say interns. I'm Canadian and we don't use the terminology of interns, so I keep on saying residents, but I know these are first-year residents or interns. So I want to take a pause. We're going to come back to the scary map that Charlotte is in. She's gone through years and years of this at this point. She has finished residency. She's gone through her exams. She passed her exams. They're very scary, but she passed them. She's now at the stage of licensure. What's involved? This is actually the research that I'm doing now is issues of licensure. And there's been some really amazing research in the States that preceded this, both by Derby's team at the Mayo Clinic, as well as Katie Gold. Charlotte, we're going to do a Canadian example because I'm Canadian, and this is some of the work that I've been working on recently. She's now a final year resident in psychiatry in Ontario. We know she has generalized anxiety disorder in the past. She's been able to kind of manage that throughout medical school and residency, but she did experience a depressive episode last year, and she took a 3-month medical leave from training. She sought treatment. She was able to make a gradual return to her clinical duties, and she performed well. Like she's conscientious. She's a good resident. She receives a job offer in Ottawa where she trained. She applies for independent practice license from her college or her licensing board. And this is the application. This is a screen cap of the application for the license. So she has to go through these questions now, and I'm going to take us through. Do you currently have any medical condition that affects or could affect your ability to practice medicine? She's like, well, my depression's in remission. My generalized anxiety disorder is well controlled. I'm just going to say no. Even though she's a psychiatry resident, she knows that these conditions are chronic and managed. But she says, you know what? I don't want to like stir the bucket, or what is it? Stir the pot. Also, what are they going to do with my personal health information? I'm going to say no. Number 2, have you ever had any medical condition that has affected or could affect your ability to practice medicine? It's like, oh, okay, a historical question. I mean, she does. Like, she had generalized anxiety disorder. She's had depression. She had to take a leave of absence. But she's told by her colleagues, like, no, don't disclose. Like, you don't know what they're going to do with your information. Like, she's facing lots of pressures. She's like, you can imagine, like, my hands are sweating just thinking about this question. Like, what does she respond? And I've had, like, anecdotally presenting this research to physicians, like a lot of them have told me that they do not disclose in these questions, even if they do have or a history of a condition that caused some sort of functional limitation. But she presses no, because she has no idea what's going to happen if she clicks yes. And again, her illness is in remission, so she thinks this is not impacting clinical care, so why should I disclose? She then faces question number 3. Have you ever taken a medical leave of absence of any duration, from medical school, from residency, from practice? And here she's like, okay, that's a concrete question. There's no vagueness. I have to answer yes. So she does. But then she thinks, okay, what are the consequences of this? So in the application, you look at the fine print, and it says, okay, for every yes answer, provide a detailed explanation. You may be asked for additional information. For example, a current report from your treating physician sent directly to the college, which is the licensing board, outlining any medical condition, setting out your diagnosis, course of treatment, present health, and prognosis. That's a lot of personal health information to be sent. That's a big privacy issue. Suddenly having this licensing board is not going to tell you how your information is used, and also what are going to be the consequences of disclosing. So are you going to have a fitness for duty assessment? Are you going to have a mandatory psychiatric evaluation? How much oversight is going to be required once you disclose? So let's say she also gets a job offer in another province in Canada, and she applies to the licensing board there. We're going to say Alberta in this case. This is the only question that comes up on the license about health. Do you presently have a physical, cognitive, mental, and/or emotional condition that negatively impacts or is likely to negatively impact your work? It's present. It's all about present impairment, or like that's sort of the language they use in this literature, but like a present functional limitation. She says, no, I don't have a currently functionally impairing condition. She can confidently say no, and that is the end of that survey, the end of that application with regards to her health. So because of this, because people have started to notice that these questions make a really big difference into how comfortable people feel disclosing or looking for help, guidelines have come out through the Federation of State Medical Boards, through the Canadian Medical Association, through the American College of Physicians, recommending how to actually phrase these licensing questions. So they should focus on current functional impairment. They shouldn't distinguish between mental and physical health, and they should actually include information about the safeguarding of their personal health information. In the research that I do sort of critical policy analysis. So the ways that these licensing questions are when they talk about past impairment, or when they talk about, have you ever been treated for XYZ? It frames physicians with disabilities as liabilities that are a potential threat to patient safety. They may therefore be unfit to practice. And so it frames illness or experience with disability as more of a regulatory concern rather than a condition that merits treatment and accommodation. So it limits the space of possibility for us to even think about accommodations in the end. So Liselott Derby at the Mayo Clinic has talked about medical licensure questions and has linked that directly to help-seeking attitudes, which has been like really, really foundational in this area of work of licensure, which is again relevant to medical education and to health professions education, because that is the end of the pathway. And that is something that we can counsel students on and residents on in terms of what is down the path, what is down the road for you, and also which states are safe to apply to in a very real way, in a way that, you know, how is disclosure going to impact your medical license? So in the study that her team did, they looked at the 51 state medical licensing applications, and they coded them as consistent or inconsistent with recommendations. So either they limited questions to current functional impairment, or they asked about any history of mental health challenge or impairment, of mental health challenge regardless of functional impairment. So they found that only 33.3% were consistent with the guidelines. I will say that since that time, new research has shown a much higher degree of compliance or consistency. And that's Katie Gould's work, which was recently published in JAMA. I think it was about 76% compliance with this recommendation specifically of current functional impairment. And then this was back in 2017, like 2/3 were inconsistent. But then what's really, the reason I highlight this study, which is a little bit older, is because they linked it directly with care-seeking attitudes. So after this, they did a survey on care-seeking attitudes, and they showed that, you know, 40% of physicians in this large survey of like almost 6,000 respondents were reluctant to seek care for mental health conditions due to repercussions on their medical license. That's a huge amount of people saying that they would be reluctant to seek care. And what they found was that they were more likely to be reluctant to seek care if they were in a state where the licensing application was inconsistent with the recommendations. And that's an odds ratio of 1.21. So we're back with our map. we're back at the beginning of our journey and the end of our journey, where Charlotte, as a pre-medical student, has this huge path ahead of her, and she's gone through it. Let's say she has her license, she's practicing. There's still going to be things down the road, hiring, all the rest. But focusing on the educational pathway, she brings so much expertise to this. She brings so much of her personality, her intersectional identity to being an excellent healthcare provider. And yet the system is organized in such a way that she has to really understand the system and navigate it and find ways of accommodating herself and managing herself to be able to get through, because a lot of the system is stacked against her. So because of this, we have to think, and the work that we do here at the symposium is all about, why are we changing the system in the first place? Why are we paying attention to this work? Well, it's because people with disabilities are incredibly valuable in medicine. They are, I think, the best doctors, because they understand. And this is a quote that I want to leave you with. It's from Neera Jain, whose work I absolutely, absolutely love. Diverse learners with disabilities add value to the professions. A transformative approach would accept the principle that health professionals should reflect the diversity of patient populations and ensure that program development and learner populations are representative of this diversity. So what I love here is also that it's not just about having representation. It's also about having the curriculum reflect that, because we saw in the research that we talked about earlier about people feeling really like outsiders in their medical education experience because they have their own experience with illness or disability. What if the curriculum acknowledged that, a huge proportion of people in the room may have had this experience as a patient or as someone with disability? What if supervisors and preceptors were open about the fact that they've accessed care and treatment for a psychological disability? It would just be such a different environment. Like it sounds utopian from the position we're in now, and yet I think it's possible. I think transformation is possible. And sometimes I think it takes people with the lived experience and with disability to imagine a future that we can't imagine, being in a very traditional system. So I wanted to thank everyone for being here. I wanted to thank so many people who have supported me in starting to work in this area. And also so many people. I'm really, really excited and honored to be here. Thank you for being here. I'm so sorry that I can't be present today. Please feel free to email me at any time. I've had this email forever. I did all of my school at U of T. I will have this email forever. I would love to talk about your thoughts, your ideas, your recommendations and suggestions. I'm very much learning this. And I think it's a really exciting time to be learning how to be a good mental health provider, and also really intimidating. The demands of medical school, the demands of medical training are so great, and we have a huge task ahead of us. And so I think we're really lucky to be here and learn from each other. So thank you so much. And I hope you have a wonderful flight back or trip back to your respective homes.